Neoplasia or tumor means new growth. However, all new growths are not neoplasms, since examples of new growth of tissues and cells also exist in other processes like embryogenesis, regeneration, hyperplasia, etc. How can we define neoplasm? Neoplasm can be defined as mass of tissue formed as a result of abnormal, excessive, uncoordinated, autonomous, and purposeless proliferation of cells even after cessation of stimulus for growth which caused it. Tumors or neoplasms can be broadly classified into benign and malignant tumors. All tumors, whether it is benign or malignant, have got two basic components: parenchyma and supporting connective tissue. Parenchyma comprised of proliferating tumor cells, and this is going to determine the nature and evolution of the tumor. Supportive stroma, on the other hand, is composed of fibrous connective tissue and blood vessels. It provides the framework on which the parenchymal tumor cells grow. Tumors derive their nomenclature on the basis of the parenchymal component. The suffix "oma" is added to denote benign tumors. Malignant tumors of epithelial origin are called carcinomas, while malignant mesenchymal tumors are named sarcomas. Sarcos means fleshy. But of course, there are some exceptions like leukemia, melanoma, and lymphoma, which are the malignant ones. A few words about squamous cell carcinoma. Pinbock has defined squamous cell carcinoma as a malignant epithelial neoplasm exhibiting squamous differentiation as characterized by the formation of keratin and or the presence of intercellular bridges, or in simple terms, we describe squamous cell carcinoma as a malignant neoplasm of stratified squamous epithelium that is capable of locally destructive growth and distant metastasis. And this is the most common malignant neoplasm of the oral cavity. So the topic of discussion is verrucous carcinoma. Verrucous carcinoma is a low-grade variant or a warty variant or papillary variant of oral squamous cell carcinoma. In 1948, Ackermann described this lesion in detail. So this pathology is also known as Ackermann's tumor. Ackermann's tumor represents less than 1% to 10% of all squamous cell carcinomas, oral squamous cell carcinomas. As the name indicates, verrucous carcinoma is predominantly an exophytic growth. Verrucous carcinoma is characterized by well-differentiated keratinizing epithelium. Another feature is the elephant foot-shaped rete ridges. Rete ridges are the portions of epithelium that projects into the connective tissue. Even though this lesion comes under malignant pathology, histopathologically there is minimal atypia, and also, unlike other carcinomas, here we find only local destruction. The term verrucous hyperplasia describes an exophytic overgrowth of well-differentiated keratinizing epithelium that is similar to verrucous carcinoma, but without the destructive pushing border at its interface with the underlying connective tissue. Although it also occurs in other anatomic sites, it most commonly occurs in the oral cavity. In addition to the oral mucosa, verrucous carcinoma has been identified at several extraoral sites, including laryngeal, vulvovaginal, esophageal mucosa, as well as the skin of breast, axilla, ear canal, and soles of the feet. Coming to the clinical features, the tumor usually occurs in males and tends to affect individuals over 60 years with an average age of 65 to 70 years. Also seen among older females who are frequent users of dry snuff. Most intraoral cases involve the gingiva, alveolar mucosa, and buccal mucosa. However, the hard palate and floor of the mouth can also be involved. The tumor grows slowly, exhibits an exophytic papillary or warty pattern, and tends to be diffusely distributed, which is sometimes covered by a white leukoplakic film. The color depends on the amount of keratin that is produced and the degree of host inflammatory response to the tumor. Sometimes it remains in the oral cavity for 2 to 3 years and becomes an extensive lesion before definite diagnosis. If not treated properly or if left untreated, then lesions may destroy underlying structures such as bone, cartilage, muscle, and salivary glands. This is a clinical picture of a patient with verrucous carcinoma exhibiting a pebbly surface. Regional lymph nodes are often enlarged and tender, mimicking a metastatic tumor. This usually represents inflammatory reactive changes rather than nodal metastasis. Patient may complain with pain and difficulty in mastication. It is noted that a very high percentage of patients with this disease are tobacco chewers. The site of occurrence of tumor usually seen associated with the site of chronic tobacco placement. A small number of patients give history of snuff or tobacco smoke. Some patients reported with ill-fitting dentures. Tumors at anatomic sites other than mouth are not related to tobacco use. Lesions on the gingiva may grow into the soft tissue and can invade and result in local destruction of bone. Verrucous carcinoma may develop from proliferative verrucous leukoplakia or PVL, which is a precancer. Proliferative verrucous leukoplakia is a high-risk form of leukoplakia characterized by the development of multiple keratotic plaques with roughened surface projections. As proliferative verrucous leukoplakia progress, it may go through a stage indistinguishable from verrucous carcinoma, but later usually develop dysplastic changes and transform into squamous cell carcinoma. Usually, this pathology will not regress despite therapy. Proliferative verrucous leukoplakia has a strong female predilection. 1:4 is a male to female ratio. And in contrary to verrucous carcinoma, PVL has minimal association with tobacco use. These are the clinical photographs of proliferative verrucous leukoplakia. In the first picture, we can see a large, diffuse, and corrugated white lesions of the buccal mucosa and tongue. Second picture shows extensive thickened and fissured alteration of the tongue. Oral florid papillomatosis was a term used to refer proliferative verrucous leukoplakia and verrucous carcinoma in the past. Leukoplakia or tobacco pouch keratosis may be seen associated with verrucous carcinoma in the adjacent mucosal surfaces. Oral leukoplakia is defined by the World Health Organization (WHO) as a white patch or plaque that cannot be characterized clinically or pathologically as any other diseases. Tobacco pouch keratosis or smokeless tobacco-induced keratosis is the development of a white mucosal lesion in the area of tobacco contact. The lesion develops on habitual chewing or snuff dipping tobacco. First picture represents homogeneous or thick leukoplakia, extensive buccal mucosa lesion with an uneven whiteness and fissures. Second picture is an example of tobacco pouch keratosis. We can see a soft, fissured, gray-white lesion of the lower labial mucosa located in the area of chronic snuff placement. The gingival melanosis is racial pigmentation and not associated with keratosis. Some leukoplakic lesions demonstrate sharp or blunt projections and have been called verrucous or verruciform leukoplakia. Here we can see an exophytic papillary lesion of the anterior maxillary alveolar ridge. Coming to histopathologic features, histopathology may be deceptive and may be mistaken for a papilloma or benign epithelial hyperplasia because of papillary, well-differentiated hyperplastic surface epithelium. The surface of the tumor is usually papillary and covered by a thick layer of parakeratin. Deep crypts containing plaques of parakeratin that extends into deep spinous layer usually occur between the elongated surface projections. The epithelium is dysplastic, but severe dysplastic features are not common. The basement membrane, the structure which separates epithelium and connective tissue, remains intact, and an intense chronic inflammatory cell infiltrate is often present in the underlying normal connective tissue. The interface between the tumor and the adjacent normal epithelium is usually well defined. The vertebrae ridges are broad with pushing borders into the deeper connective tissue described as elephant foot-shaped vertebrae ridges. So, cleft-like spaces lined by a thick layer of parakeratin and parakeratin plugging are considered as hallmarks of verrucous carcinoma. In this histopathologic picture, we can appreciate extensive keratin production, forming finger-like projections and filling deep clefts. Acanthosis, which is increase in the number of spinous cell layers, with broad, blunt, bulbous vertebrae ridges compressing the underlying connective tissue. Absent or minimal dysplasia and an intact basement membrane. All these are features of verrucous carcinoma. This is a schematic picture of verrucous carcinoma. Important identification features include hyperplastic epithelium with minimal dysplastic features, broad vertebrae ridges with pushing borders, intact basement membrane, and presence of chronic inflammatory cell infiltration in the connective tissue. Verrucous carcinoma is a superficial pathology and follows a cohesive growth pattern with sharp demarcated margins. Best treatment options are either surgical excision or laser therapy. The prognosis is good because local excision is usually curative. Another option is radiation therapy, but sometimes it can result in an aplastic transformation. Lesion is slow growing and metastasis occur late if at all occurring. Sometimes treatment failures occur in patients with the most extensive involvement or in those who are present with systemic diseases. Another cause of treatment failure is the initial inability to identify a focal squamous cell carcinoma arising during, along, within the less aggressive verrucous carcinoma. Approximately 20% of verrucous carcinoma has squamous cell carcinoma developing simultaneously within the tumor. Therefore, adequate sampling and follow-up is important because of this close association with SCC or squamous cell carcinoma. Verrucous carcinoma containing foci of conventional squamous cell carcinoma should be treated as conventional squamous cell carcinoma. To summarize, verrucous carcinoma is a warty variant of squamous cell carcinoma characterized by exophytic growth of well-differentiated hyperplastic epithelium. Verrucous carcinoma can be differentiated from squamous cell carcinoma by mode of growth, degree of dysplasia, and absence of metastasis. Verrucous carcinoma must be differentiated from verrucous hyperplasia as the latter lacks pushing borders histopathologically. And of course, there are some clinical differences. The etiological factors responsible for this tumor is consumption of alcohol. Human papilloma virus also has a role in the occurrence of verrucous carcinoma. Tumor present with male predilection and is usually seen above 60 years of age. Verrucous carcinoma is a slow-growing exophytic tumor with low metastatic potential. Tumor clinically present as papillary in nature with pebbly surface, sometimes covered with white leukoplakic film. Histopathologically, verrucous carcinoma exhibits hyperplastic epithelium with minimal cellular atypia. Deep clefts present between the papillomatous growths are filled with parakeratin, which is one of the hallmarks of verrucous carcinoma. These are my references. Thank you.